From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to our listeners around the world. You're listening to JAMA Surgery Author Interviews. Thanks for joining us. I am your host, Dr. Amalia Cochran. Our topic today is derived from a review of molecular testing and targeted therapies in hepatobiliary cancers. And I'm speaking with the senior author, Dr. Tim Pawlik, who's the chair of surgery at The Ohio State Wexner Medical Center. Welcome, Dr. Pawlik.
Thank you, Dr. Cochran.
I'm really looking forward to talking to you about this review. As someone who does not have content expertise in this area, it was helpful for me to learn a lot of the things that are state of the art. And so I'm hopeful that our conversation will help people who are less versed than you are in this and make it a little bit less intimidating for those folks.
I look forward to it. I'll do my best.
I would love to start with the why of your review. What is particularly important or impactful right now about molecular testing and targeted therapies for hepatobiliary cancers?
Yeah, thanks again, Dr. Cochran. I think it's just a very exciting time in cancer in general with regards to immunotherapy, targeted therapy, and in particular for hepatopancreaticobiliary malignancies. These are cancers that traditionally have a very poor prognosis. And although we try to operate on patients, even those patients we operate on, many will recur. And even traditional chemotherapy, cytotoxic chemotherapy, has provided only kind of a modest benefit for these patients. So the notion of immunotherapy and targeted therapy for these patients has really opened up considerable opportunity to improve the prognosis of patients who have HPV malignancies.
Let's start by talking about the recent National Comprehensive Cancer Network, or NCCN, guidelines for molecular testing recommendations for hepatobiliary cancers. While the guideline update didn't recommend routine molecular testing for hepatocellular carcinoma, you provide some important recommendations around some very specific testing. Please tell me more about the clarifications that you offered on these points.
Yeah, thanks, Dr. Cochran. So as I was noting, now with next generation sequencing, it's really revolutionized how we think about these cancers. The NCCN currently recommends routine molecular testing for biliary tract cancers, including intrahepatic and extrahepatic cholangiocarcinoma, as well as gallbladder cancer, because there are a number of very specific targets, molecular perturbations that can be targeted. For example, IDH1, or an FGFR2 mutation, a BRAF mutation. However, for hepatocellular carcinoma, NCCN currently does not recommend routine molecular testing. However, in a new era of kind of agnostic therapeutics, in other words, therapeutics that are based on your specific molecular mutation rather than your histologic or anatomic diagnosis, there may be a role for more molecular testing for patients with HCC. So let me give you an example. One example would be ERB2, or formerly known as HER2. This is a molecular pathway that has been very well studied in breast cancer patients. We are learning now that a small subset of HCC patients may have an ERB2 mutation, and therefore they may benefit from molecularly targeted therapy with agents such as trastuzumab or pertuzumab. And therefore, we should start to think more broadly about who does and does not need next generation sequencing.
I actually was specifically curious about the role of molecular profiling in patients with hepatocellular carcinoma, because when I looked at the figure number 1, which is the molecular classifications information, the phenotypes that are available using simply proliferation versus non-proliferation class seems to be very helpful for classification. So what I'm hearing from you with what you just spoke about, really the molecular profiling can play into the current state of either adjuvant or neoadjuvant therapies for these patients.
Yeah, so I think, again, it's interesting because traditionally we think of classifying patients with HCC or other tumors, frankly, relative to like morphologic factors. How many tumors do they have? How big is the tumor? Is there vascular invasion? And I think what figure one in the article highlights is us pivoting more to a molecular classification. And in HCC in particular, we tend to think of a proliferative versus a non-proliferative subclassifications. And these two different subclassifications can have kind of different molecular profiles. For example, the proliferative class of HCC tends to have more RAS and AKT, mTOR, or MET mutations, whereas the non-proliferative class tends to more involve the beta-catenin pathway. And we also see in the proliferative pathway that these patients tend to have more poorly differentiated tumors, higher AFP levels, and have worse outcomes compared to the non-proliferative class. So to specifically get to your question, this set of individuals that are classified as having proliferative tumors based on their biological phenotype probably would benefit more from both preoperative chemotherapy and adjuvant chemotherapy. We're lucky because unlike 10 or 20 years ago, we now have therapy that is efficacious to treat patients with advanced disease and hepatocellular carcinoma. And in particular, Tazo-Bev and other agents have been shown to have efficacy in treating patients with advanced HCC. Those are data from the IMbrave 150 trial that showed superior overall survival and progression-free survival for patients who received Tazo-Bev versus sorafenib.
Biliary tract cancers appeared to me, based on your review, to be much more complex from the standpoint of molecular profiling already in this moment being relevant to targeted therapies that are available. I'm a novice in this space, like I already said, and so I would love any insight that you can share about why this might be true, because it does seem so different from hepatocellular carcinoma.
Yeah, I don't know if I would say that biliary tract cancers are more complex. If anything, HCC may be proving the harder nut to crack, if you will. I think we have benefited from all the work in biliary tract cancers that there's a number of mutations that have been identified and are targetable. So I think that has been a great benefit for those patients who have biliary tract cancers. Unfortunately, with HCC, there hasn't been as many molecular markers or mutations that have been identified that are targetable. And it may be because HCC is more heterogeneous with regards to the molecular perturbations that characterize that tumor. But as I mentioned, we are making some inroads with immunotherapy, with the IMbrave 150 trial and other more recent trials that have shown that the combination of immunotherapy with either anti-VEGF therapy or other chemotherapeutic agents may provide a patient benefit for individuals with HCC.
That clarification makes a lot of sense. Is there anything else that you think is important for our listeners to grasp about the current state of the art in molecular testing and targeted therapies for hepatobiliary cancers?
I think I would just emphasize the importance of molecular testing. The last part of the article, again, highlights this notion of tumor agnostic therapies and moving away from thinking about how do we treat patients based on histology, based on diagnosis or anatomy, and really moving towards thinking about how do we treat patients based on their specific molecular profile of their tumor. And I think what's really exciting is some of the work that Dr. Jason Siklik, who's at UCSD, and others are doing around this concept of N of 1 customized therapies. So each patient, in essence, almost acting like their own clinical trial, and patients having their tumors molecularly profiled, and then using data from all tumors, all cancers, and perhaps even using AI to help us understand how we can best target all the different molecular mutations and perturbations of your tumor and bring off-label or tumor-agnostic therapies to bear on treating your tumor, I think is where the future leads. And we can only really do that is if we collect these molecular data on patients. And I think although the NCCN recommends collecting these data in patients with advanced disease, sadly, many patients with biliary tract cancers will recur. And when they do recur, will often fail first or second line traditional therapy. And so having this molecular data on hand is helpful because it may identify targeted therapy either as part of a clinical trial or off trial that you can offer patients who have failed traditional therapy.
My closing question for you is really, again, capitalizing on your expertise and your experience in this space. And that is, what is your hope for what happens next?
Well, I think my hope for what happens next, I've already, I think, articulated a little bit, and that's like true individualized medicine. Personalized medicine, I think, is basically looking at, populations of people that maybe have the same molecular mutation. And then we target that population. If this population has IDH1 mutation, we target that. But, this is way more complicated than a single mutation. So usually multiple different pathways are impacted. There may be several mutations that are in play. And I think some emerging data suggests that rather than targeting these mutations in a serial fashion with different agents, but perhaps early on targeting them simultaneously may be not only safe and feasible, but more efficacious for a patient. And I think that is what I think is exciting in the future, is that we can move towards this concept of truly individualized, personalized therapy to treat people's cancers.
It's a great wish. Dr. Pawlik, thank you so much for your time today.
Thank you, Dr. Cochran. I really appreciate the opportunity to chat with you.
I am Amalia Cochran, web and social media editor for JAMA Surgery, and I've been speaking with Dr. Tim Pawlik about his review of molecular testing and targeted therapies in hepatobiliary cancers. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.